Welcome to the North Star ALS podcast, where ALS science meets ALS families. I'm Nadia Sethi, co-founder and CEO of North Star ALS. Our mission is to make ALS research more understandable, more accessible, and more connected to the people it ultimately serves. We help families connect with research opportunities, provide context around emerging scientific discoveries, and bring the experiences and perspectives of people living with ALS back to the researchers working to change the future of this disease. Today, we're exploring one of the most important and rapidly evolving areas in ALS, genetics. From genetic testing and family risk to precision therapies and large-scale research initiatives, genetics is transforming how we understand ALS and opening new possibilities for treatment and care. I'm delighted to welcome Donna L. Bernstein to this podcast. Donna is a board-certified genetic counselor with deep expertise at the intersection of genetics, patient advocacy, and therapeutic development. Throughout her career, she has helped lead sponsored genetic testing programs, newborn sequencing initiatives, rare disease registries, and research collaborations that connect patients, clinicians, laboratories, and industry partners. She is also a passionate advocate for genetics education and one of the most compassionate voices in the field, helping families navigate some of the most difficult and emotional decisions they may face. Donna brings a rare combination of scientific expertise, practical wisdom, and genuine empathy to her work. She also understands these issues on a deeply personal level, having navigated genetic testing and inherited cancer risk within her own family. Donna, thanks so much for being here today.
Well, thank you for that lovely introduction. I'm very happy and excited to be here to talk about this today.
Wonderful. So we have lots of good questions for you today. So Donna, you've spent your career helping families understand genetics during some of the most challenging moments in their lives. Looking back, what first drew you to genetic counseling and what continues to inspire you today, especially as genetics becomes increasingly important in diseases like ALS and FTD?
Well, I've always loved science and especially genetics, and I just found it fascinating. For me, I really enjoy making something that's very complicated science accessible to patients and to physicians who may not specialize in genetics. So that's one of the things that I really like doing. I also feel that if I can help be with people during difficult times and what they're going through, that's something that's worthwhile and a really a gift worth doing and spending my time and abilities on. And there's so many amazing advances in science right now that any opportunity to contribute to it and be a part of it is extremely inspiring and exciting, especially if they can lead to improved outcomes for people living with ALS, or at least make an incremental difference.
Thank you so much for that, Donna. And you've had to experience, the other side of genetics personally. Your mother had a pancreatic cancer diagnosis, and tell us about that. Tell us about the uncertainty, the decision making, and the impact of genetic information. I had the chance to talk with you about this a little bit before, and your story was really impactful, and meaningful.
Yeah, thank you. I think a lot of clinicians are on both sides of the table sometimes and come into our roles because we are facing our own genetic concerns or health considerations, can be motivating. But what I learned really is that it's not so easy to face a life-threatening illness, especially the genetics. The genetics actually, for me, wasn't the hard part because I have a background in training in genetics, but certainly, I guess I feel that having some uncertainty and having health issues are really a part of the human condition because of the experiences that I've had in my career and personally. But it was also very valuable to me because I learned that there really are some heroes out there who are going to champion for you. but you got to find them because a lot of people will not. Our medical system has not caught up with technology, and that can be really, really frustrating and difficult. And it requires really in-depth research. And, I don't think I would have had the same experience had I not had a background in genetics and colleagues who really knew cancer genetics to steer me in the right direction. But fortunately, I did. And I pushed hard, and I got pushed back, and I pushed again until I got my mother into a clinical trial that was gene targeted. So the first thing I had to do was push for her to get her tumor sequenced, which I don't know if that would have ever happened had I not said, no, this is where you send it. This is the lab. And it's called Foundation Medicine, just to call out to them because they were so wonderful. And, they helped find what genes were not working properly in her tumor, what were mutated in the tumor, and targeted therapies and companies that had clinical trials for the problem that her specific tumor had. And I pushed until I got her into this trial, and it took a couple of months. And I still wonder what would have happened if she had gotten in earlier, not just for my mother, but for the clinical trial. Early intervention is so essential. So if somebody has to wait for progression, that's not going to help anybody. But that was the rule at the time. But we finally got her in, and it gave her an extra year and a half of life, but not just life, but quality of life. So she was going to conferences and galas and living her life, boat rides, and she didn't have pain. So that was phenomenal. That's really all you could ask for. And, she was in her 80s. But the other thing that I learned, which is, I knew this already, but I experienced it, and I was very fortunate, was the company that ran the clinical trial didn't require a placebo group. So it was open label. And, if there's a life-threatening condition, you want every chance that you can have. So that was very comforting to me to know that she's going to get the study drug, and she did. And then she eventually, when she became ineligible, and that's a long story, she left the study because and then, we realized her only chance was to continue the medication. The company allowed her compassionate use. So those are two things that I will always be grateful to Tango Therapeutics for really caring about my mother, and showing it with their actions. And so I feel like we don't always see this in clinical trials, and we can do better. And there are ways that we can make clinical trials really the best we can for patients who are already going through a difficult time. They don't need to have more pressures and difficulties. We want to help as much. That's what we're doing this for. We're doing this to help patients. So those were really the positives that came out of this. And I think this company is really succeeding. But again, it's not easy. So if you have somebody who speaks medicalese and who will push for you, that's really important. Somebody maybe like Nadia. So.
Yeah, I think, in ALS at least, and you've had some experience in ALS, we're seeing a shift more towards more genetic testing now that we have tofersen available. And it's really made a big difference, even in the 7 years that I've been in this space. And so, but I think your story just resonated so much because I don't think that we often realize that our clinicians also experience these things in life where they have to be advocates and they have to push for change. And all of these things that you're mentioning are very relevant in ALS. And so I'm just really grateful that you shared this incredible story.
Well, that's the one silver lining of going through difficult health situations is that it helps you understand what other people are going through and hopefully be more compassionate and supportive. And so that's the gift that it brings.
Absolutely. Now, you've said to me before that, and this really stuck with me, that genetic testing doesn't really change anything. It just puts a name to it. What do you mean by that? And why can having a name still be so powerful for people who are going through a rare disease diagnosis?
Yeah, I think what I meant, I mean, genetic testing hopefully can change things in a good way, but it doesn't change the fact that we have a condition. So whatever genes we have, we're usually born with them. And so they're already there, and the conditions that are associated with them are already there, or the predisposition for them are already there. So that's what doesn't change. But what changes is that it can empower us to do something about it, hopefully. And it might be that there's a therapeutic, and that's great, but it might be just to have insights and understanding what is the cause. This wasn't something I did wrong, or this, and it never is. And nobody would choose to have ALS or another genetic condition. But it can also help us understand what to expect, predict, what might happen. And it can inform the correct medical monitoring and interventions when they exist, or treatments or clinical trial eligibility, which we talked about, but also life decisions. Like maybe you want to have children earlier, or you want a different career, or you want to go on that African safari now, or financial or reproductive planning it also enables. So I personally feel like knowledge is power, and there's a lot of great things that it can inform us. If having that information just gives us the ability to make informed decisions about our lives and our medical care. So those are good things.
Absolutely. So, yeah, and kind of building on that, many people get a diagnosis. ALS is a really complicated diagnostic process, right? We're trying to eliminate what what this isn't. And then we land at ALS a lot of times. And now there is some genetic testing, but many people get a diagnosis before they've ever had genetic testing. And so can you explain to us the difference between a clinical diagnosis and a genetic diagnosis, and why might that distinction matter in a disease like ALS?
Yeah, no, what you said is exactly spot on. You hit the nail on the head. They call it a diagnosis of exclusion, meaning that you have to rule out everything else. And then if there's no other cause, which is really because they want to make sure there's nothing that can be treated more easily before, giving the diagnosis of ALS, which is not easy to treat. But and there is heterogeneity in the presentation, so there are a lot of different kinds of presentations. But the thing that I worry about with this sort of diagnosis of exclusion is that although there are things that can distinguish ALS from other conditions like electromyography and denervation and things that really are lower motor neuron, and so specifically associated with ALS. There can be other conditions that also cause muscle atrophy. And without a biopsy, it's really, a probable diagnosis. It's not necessarily a definitive diagnosis. And if there's another condition that's masquerading as ALS that could be treatable, that I think is something that's really important to know. And right now, even the genetic testing doesn't always look at that. So I feel like we need to improve in so many ways. But genetic testing is not as invasive as a biopsy. So for the people who have a variant, which is about 15% of people are expected to have a pathogenic or likely pathogenic, which are treated the same variant in an ALS-associated gene. It's pretty definitive for those people. About 35% of people have a variant in an ALS-associated gene, but that's if you include what's known as variants of unknown significance. So we don't always know how to interpret a variant. If it's very rare, it's never been published before, there's no evidence. So that doesn't mean that we don't know if it's disease causing or not. It could be, but we need to learn more. So that's quite a large number of people. And then I'm going to guess we're going to learn more and more about new genes. And so those numbers will only grow. But, again, we talked about how having that variant can be informative in terms of what to expect, and also potentially being able to receive that targeted therapy in a clinical trial or commercially. The gene targeted therapies I like because I understand them, right? So because we're looking at the underlying molecular pathophysiology of the condition, and that's what we're trying to address. So we hope that this will slow or stop the disease progression, unlike something that's just sort of trying to address the symptoms, which is important too. But it's pretty exciting if we can actually change the course of things and stop getting worse and maybe even get a little bit better. And that's sort of the hope of genetics and genetic testing for ALS. And then the other thing that genetic testing offers that is kind of complicated is predictive genetic testing. So if you know that there's a variant in your family, then people who have not developed any signs of ALS yet can also be offered genetic testing. For that, I strongly recommend genetic counseling because they can offer anticipatory guidance, and there are a lot more considerations about the benefits and the right timing. And there are some risks too about getting genetic testing before you're symptomatic because there could be discrimination. So these are things that are important to discuss with a genetic counselor. And there's pretty well-established protocols for predictive genetic counseling for genetic counseling prior to predictive genetic testing to protect patients really from discrimination mostly.
Are you seeing an increase in genetic counselors in general? I feel like not everyone has access to a genetic counselor, and I've run into that a lot, where it's somebody else in the clinic who's having that discussion with them.
Yeah, and unfortunately, that's 100% correct. And it's also, I mean, a lot of people who have ALS don't even receive pre-test genetic counseling, which I think that everybody should have pre-test genetic counseling because you want to know what you're getting into before you get into it and make a decision because I think it's great and empowering and important, but somebody else might say, look, I don't want to know. I don't have children. I'm not going to change my management. I don't want to be in a clinical trial, go away, leave me alone. People have the right to make these decisions that are best for them, and it should be based on their values. But for me, because there are interventions, because there are things that we can do about it, if there is a genetic variant, I feel like if you have ALS, certainly it's really important to get genetic testing as early as you possibly can, because it can make a difference. It can help. So hopefully, not for everybody, but for a number of people. So that's what we want to do.
Yeah. And I think I've talked to so many people over the years that have found some genetics or have found genetics that did make a difference in their treatment options. And so it does matter. And on that note, we often hear that therapies like Qalsody only apply to a small percentage of people with ALS. And as someone who has spent her career in rare disease, how do you react to that framing? And what does it miss about the bigger picture of ALS and other rare diseases?
Well, it's understandable because, so far about what we've learned from genetic testing of ALS patients, and we tested a lot of them. I was really fortunate to be involved in that for quite a while. About 15% of patients, as I mentioned, have, and this is agnostic of family history, so it's a little bit more likely with people who have a family history, but whether we know you have one or not, 15% of people with ALS will have a pathogenic or likely pathogenic variant in an ALS-associated gene that is presumably causative. So that means, yes, 85% will not, but it depends how you look at numbers, and numbers are tricky because they're subjective, believe it or not. We think that they're objective, but they're subjective because another way to look at that is that more than 1 in 7 people will have a variant in a treatable gene, in a gene that is associated with ALS, and many of these are treatable. Not all of them, but many of them. And I guess I did a calculation that for when I was looking at all of the data, which this is what I do with the data when I get the de-identified variant data, is I calculated that 12% of people would have a variant in an ALS associated gene that either had a commercially available or investigational therapeutic that was gene targeted. However, that was when there was an ataxin-2. This is getting too technical. There's another clinical trial that they don't have anymore. So now the number would be a little bit lower, but it's going to get higher. Now it's actually even higher for other reasons because there are more and more genes that are being targeted with gene-specific therapeutics. So that number is out of date, but it's still, interesting to think about it. So that's pretty significant, that more and more people are going to be able to receive a genetic diagnosis or have an informative genetic test. Sometimes it's not perfectly, some genes are increase your likelihood of having ALS, but are not necessarily going to cause ALS. So those are the difficult ones to navigate. But even they can hopefully, benefit for many reasons too, to say, okay, now my risk has changed, and that's also can be helpful. That also can be helpful information. But as far as also SOD1, so if 15% of patients have a variant pathogenic or likely pathogenic, 35% have a variant, including variants of unknown significance. Well, SOD1 accounts for about 16% of genetic ALS in Europeans and about 32% in Asians. So that means that's so about 1 in 20 to 1 in 40 people with ALS might be able to receive Qalsody. That's pretty significant. And this is my back of the cocktail napkin analysis that I did, but I think the numbers are pretty compelling. And there are going to be a lot more targeted ALS gene therapeutics, and it's super exciting, and new genes.
Yeah, absolutely. And that's why we're doing this focus on genetics and more targeted therapeutics at North Star. So families are often surprised, so we often hear about the heterogeneity of ALS, and we hear that in a lot of diseases, but I think that we're starting to see that there's also heterogeneity within a specific gene. So all people with FUS or all people with SOD1 mutations don't necessarily have a disease course that, goes the same way. And even within a same family, you may see differences from person to person where they're carrying the exact same mutation or the exact same variant, right? So why does that happen? And how, I guess on the research side, how do you navigate that? And how did you navigate that with families?
Yeah, it even happens with identical twins. So that's so you're asking me the tough questions today. They're not so easy to answer. Well, some of them are easy to answer. For example, like FUS ALS, which I know quite well. It depends on where in the gene the variant is. So this would be why different variants in the same gene would have a different presentation. So for example, if there's a variant that's very early in the gene, that can just be associated with isolated tremor and not even cause ALS. So that is, and then if there's a variant in another part of the gene called the nuclear localization signal region, those variants are unfortunately very severe and can cause an early onset form of ALS that's very rapidly progressive. So we know that, but even within that, there were twins who both had the same variant in that FUS ALS nuclear localization signal region, and one of them progressed over a few years, and one of them progressed over, less than a year. So, what happened there? I don't know. There must have been a few possible explanations. Could be environmental factors that we don't know about. That we have 2 copies of every gene, so maybe one, that second copy became affected sooner for one of the sisters than the other. It could be that there are genetic modifiers. Now, identical twins, it's hard to think that there's genetic modifiers, but there's something called, and this is too technical to stop me, but it's called post-zygotic mutations. So that means that after the fertilization event, during embryogenesis, mutations can occur in one or two of those cells. And so that can spread to many, many cells of the body or all the cells of the body if it's at the totipotent stage. Whereas, so one twin can have a post-zygotic variant and the other might not. But there are obviously environmental factors that we just don't understand very well and we don't know about. So we call those gene modifiers. And the other thing that can happen, and this wouldn't be, well, the more common thing are there are risk alleles that, depending on the number of these, are called expanded repeat conditions, and the number of repeats can change the presentation of the condition. So that's one explanation if you have a bigger size variant or a smaller size variant. But the other thing that we discovered in the research it was about 10% of people, which I was very surprised, they have more than one variant in an ALS gene. So, and again, this would not apply to twins, but for you in a family, one person could, it's sort of like the drawing straws or a lottery, like one person gets one variant and one person can get two variants, and that can affect the outcome. Then there's super technical things, like if there's a repeat that's interrupted in something like ataxin-2 or not, that can change that age of onset. So there's, lots of things. Our genes are really interesting because they can tell us so many things, but not everything. So they're, and I like that because that means that we can do something about it. We don't have to just become, resigned to whatever this is, what your dice are cast. They're not. We can still change the expression of our genes, and we can, we can still always, there's always hope. It's important to know that.
There is. And genetics is evolving rapidly, like we're talking about, from gene panels to whole exome sequencing, whole genome sequencing. And now I'm hearing a lot about long read sequencing. So what are some of the key differences, and why am I hearing so much about long read in recent times in ALS and FTD specifically?
Well, that's really cool stuff that's going on. So I'm going to date myself now. I'm not as young as I used to be, but I guess none of us are. So when I first started in genetics, genetic testing was done by something called Sanger sequencing, and it's really labor intensive. And you look at one gene at a time, and it costs thousands of dollars just to look at one gene. If you know the variants you're looking for, that's much easier and less expensive because you only have to look at one little part of the gene. But to look at an entire gene was a big deal. Now there's, massively parallel genetic testing called next generation sequencing. And we look at hundreds of genes at once. So, and now we can look at the whole genome at once. And so exome sequencing is when you look at the part of the genes, all of the genes in your genome, but only the parts of the genes that actually are encoding proteins. So that's what we know the best, and that's what we understand. Because if you make a mistake in the instructions for making a protein, the protein's not going to come out right, and it's not going to do its job. So that's sort of the easiest thing to understand. But there are also intronic variants. So the introns are spliced out of the gene during the protein making process. And those introns can have important things in them. There's no waste in biology, right? So they can have instructions for gene expression or regulating genes, or even the instructions for how to splice the genes together. And so their whole genome sequencing looks at everything: the introns, the exons, so the part that makes the protein and that doesn't make the protein, every single part of the gene. And that's great too. However, you'd think that would be comprehensive, but it's not. Just one-stop shopping, because there are variants that are large missing pieces of a gene, or extra pieces of a gene, or genes that are in the wrong place, or they're inverted, they're called inversions, structural variants, and we're not good at that. Whole genome sequencing doesn't find it on next generation sequencing. And also these, I think I mentioned the expanded repeat genes, where there's something, the same sequence of DNA repeated several times. And if you have the right copy number of them, if you have, let's say, less than 25, then you're fine. If you have too many, then you can have a problem like some forms of ALS. So the regular whole genome sequencing doesn't pick those up either, or they didn't. But and there's other things too that long read sequencing can do all of this, because they look at bigger pieces of the DNA, and it's easier to analyze that. It can look at which parent of origin a variant came from. It can look at things called methylation, which is in gene expression. It can look at all of these structural variants in one test, but of course there's a catch. It's very expensive and it takes a long time. So now the company called Illumina, that makes the next generation sequencing and does a lot of whole genome sequencing, have a new way of analyzing their sequencing data, so that they can look at really essentially almost all the same things as long read, but it's only on a research basis so far. So that's kind of in the future. But soon, there we'll be able to look at everything in one test. But for now, the fact is that no one test can detect every kind of variant, even long read. So that's why we have to be careful when we do genetic counseling, and when somebody tests negative, say, well, this is a negative test, meaning we didn't find anything, but it's, we only really can say 100% you don't have this genetic cause when there's a family member that does, and you didn't inherit that. And then, there's still a small chance that you have something else. So there's always some uncertainty. But really what I learned back in graduate school, which I keep in mind all the time because I had a wonderful instructor, said we've got to know what we know and what we don't know. And there's a lot that we know, but there's still some things that we don't know, and we're doing better every day. So.
Yeah, absolutely. I think those gaps are really important to recognize also, especially in the clinical setting when you're talking to somebody, to let them know what might be missing is so important. So Donna, you've worked extensively with rare disease registries and large genetic data sets. What excites you most about what these efforts might unlock or lead to for diseases like ALS and FTD?
Mm. Well, the most exciting thing is if we can do something about them, right? So if we can lead to more therapeutic interventions for more forms of ALS. The other thing that, I am very hopeful about, and it's kind of, I think a lot of people are thinking about this, but so we talked about a couple of the genes that we know are associated with ALS, but, and I know, Nadia, you're very up on this too, that there's hope that some of the genetic forms of ALS can lead to treatments for the other, 80 something percent that doesn't have a variant. Because we know that a lot of the proteins that are misfolded and that are aggregate in the genetic forms of ALS also are present in the neurons of people who have sporadic ALS with no known genetic cause. So ideally, if we can do something about lowering the amount of the misfolded proteins in genetic forms, maybe this will also apply to the regular form. So that's the best thing we can do. But what do I do with the data? A lot of what I do is I look to understand the genetic forms better. So I want to understand, well, what do the variants tell us? So, we want to be able to counsel patients and say, everybody who's been published who has a variant, this same variant as you, have these outcomes. Does that guarantee that you'll have the same? No, but does it make it more likely? Yes. So we want to be able to understand maybe certain variants have a different age of onset, or maybe certain variants are more common in different people of different ethnic groups. So maybe we need to know what to look for in different people, or maybe they have, different ways that they respond to things, different sites of onset. And those are the kinds of things that I like to look at. Just what can we learn? The other thing I like to look at is to see these variants of unknown significance, because there's a lot of them. There's more variants of unknown significance than of known significance. So like if I can figure out like, oh, look at this, there are 14 patients who have the same VUS and they all came from, different backgrounds and they all had onset at some age. I go, this looks really real if they're not related. So we can learn about these variants of unknown significance, and then I like to publish them, or I like to tell them, bring them to there's big databases for geneticists to look at. And so I would report them to the databases, and then they become known significant. So we can increase the number of variants that we understand better through the data that we look at, through the patients and the people who are being able to give us their DNA. We can also look for new genes that cause ALS, and that's something I'd really like to do. And I would really like to look at these, what I call phenocopies, which are these other conditions that look similar to ALS, but maybe they have another cause. And I want to know, well, how many patients who are diagnosed with ALS actually have another genetic condition, and maybe a treatable one? So I want to learn that. And the only way we can learn that is that we can look at the genomic data, or at least the exomes ideally the genomes of people with ALS, and try to figure out if there's something we're missing. So those are the kinds of things that I like to learn about from the data. It's pretty interesting and keeps me out of trouble.
It's very interesting. And as we're seeing more targeted therapeutics and precision medicine become a reality, how is the role of genetic counseling changing? We're not, there may not, you're talking about more rare variants that might be happening or variants of unknown significance. So how is all of this evolving as we're looking to more precision therapeutics?
Well, I think genetic counselors are becoming involved with this. I think we really have to make sure that genetic counselors are up on all of the clinical trials, especially the genetic targeted ones, so that they can be a part of this and help their patients find the right study for them. I know that when I was working on a clinical trial for FUS ALS, and I love the neurogenetic counselors. They're fantastic. They're the smartest people I know. They know a lot more than I do about ALS and genetics, but they didn't know about our clinical trial. Some of them didn't. And I say, oh, we sort of have to make sure that the genetic counselors are working with the biopharma companies and the labs, and everybody's working together. So like my worry was, and this was real, because I know that people don't always share data. I believe that this data should be shared with everybody, and we should all, and especially the clinicians, the doctors who can probably learn the most from it and make the best use of it. But there are people who are getting genetic testing for ALS, and people who have variants, and they're not being told that there's a clinical trial for their variant, or they're not being told that there might be a treatment for their gene and variant. So we need to make sure that the doctors and the genetic counselors are all communicating. I think genetic counselors are good at that. I think that they can really look up the clinical trials and find the best, most appropriate therapeutics, and make sure that the physicians are informed and the patients are informed, and then give them the option, because not everybody wants to participate in a clinical trial, but you should have that opportunity. And the other thing I should mention when I said that is that right now, and this is a little off topic, but just for talking about genetic testing for ALS, we talked about how a large proportion of patients, in my opinion, and it's all relative, but a number of patients are going to have a variant that might be treatable either commercially or in a clinical trial. But the problem with the clinical trials is there's eligibility criteria. So I think it's important to go into that knowing that if you do have a genetic variant, it doesn't guarantee that you're going to get into a clinical trial. I think it should, and I think there should be compassionate use. And if it were up to me, there would be, but it doesn't always work that way, because they have to, they want to get the drug approved. So they want to only include the people that are most likely to respond, meaning not too advanced a lot of the times. And I think there should be they just separate the analysis. So, but there are ways to do it, and I think we can do it. But and I think that's something that we need to advocate for.
Yeah.
But just to know that it's not guaranteed. But yeah, there are not enough genetic counselors. The wait time is too long. We need to get genetic testing done right away. Like the delay from onset to diagnosis can be a year, and ALS diagnosis, and then another. It was actually from ALS diagnosis to genetic testing. Then the mean, I'm saying the mean or the median, I think it was actually the mean time from ALS onset to genetic testing was 2.5 years. That's way too long, because sometimes it depends on the kind of ALS. Some of it's slowly progressive, some of it's quickly progressive. But if it's quickly progressive, that's too late. We've got to get this, as soon as there's a suspicion, I feel like the first suspicion of ALS, genetic testing should be done. So at least those 15% can just know for certain what's going on and have access to a potential therapeutic. And, hopefully that number will continue to grow and grow. So it'll be a larger and larger percent of ALS patients.
Absolutely. So we've talked about the science, the technology, the personal side of genetic testing. And I don't like these types of single, tell me the one thing, but I'm going to put you on the spot here. If there was a one major thing you could change about how genetic information is delivered or used in ALS care today, what would it be?
Yeah, I mean, the most important thing is to have that information available as soon as possible, which is what I mentioned. Like the delays are not acceptable.
Yeah.
So that will be the most important thing. And I also believe that genetic counseling should be done. The pre-test should be offered to everybody and the post-test. But I'm an idealist. It's not like I think if the options are wait 10 months to get an appointment with a genetic counselor or skip the pre-test, you can skip the pre-test. But there are actually companies that I think they're good genetic counselors, but I think the best is in person, because in person in a hospital setting, the genetic counselor will look at the chart, they'll look at everything. You'll have that, continuity of care. They'll help get you the right specialists. But if you don't have access to that, or if it's much too long, there are third-party genetic counseling services that are available either through diagnostic labs like Invitae or prevention, not for genetics. There's companies like Genome Medical that offer genetic counseling that, again, it's not quite the same level as in person in a hospital setting, but it's still important to do that if you can't get access sooner. But the other thing is there's usually a way. I had a patient call me and say this was not for ALS, it was actually for another terrible neurodegenerative disease, a prion disease, and he couldn't get an appointment with a genetic counselor for 10 months where he lived. And I made a few phone calls and we got him one the next week. So like there's ways to do it. It's just not, being from New York, I think I never take no for an answer. I think we have to be relentless and perseverant, and that's what it takes. And sometimes, it takes a lot of energy to do that. So maybe if you have support and a helper and some support system, or a place like North Star that can help empower people to get the best genetic counseling, genetic testing, and find the best clinical trials, that's an amazing thing to have.
Yeah, I think these are definitely the ALS is a disease that really makes you feel disempowered, right? And so I think a lot of what we do at North Star is, support people in advocating for themselves so they can make more informed decisions and have better conversations with their doctor. But yeah, sometimes our healthcare system is very difficult, and we do have to advocate for ourselves and push for ourselves. And you were a great reminder of that today, even in your own situation with your family. So we appreciate you so much, Donna. Thank you so much for taking the time to talk and share with us today.
Well, thank you for having me. It's a pleasure, always.